Hello and welcome to the next session, One Health, Good Practices and Challenges. My name is Eckhard Hirschhausen, and some of the people in this room look familiar. Who has been on the One Health session already? Okay, so I don't have to repeat any jokes. One Health is a bit like world peace. Everybody thinks it's a good idea, but nobody knows exactly how to get there. And this is why we wanted to have these 90 minutes focusing on good practices and challenges. And instead of many PowerPoint presentations, we'll have videos from very precise projects in the countries that the BMZ works with. And I'm just the moderator. My name is Eckhard Hirschhausen. I'm a medical doctor. I work on German television, and I have a foundation to promote the idea of One Health and planetary health called Stiftung Gesunde Erde, Gesunde Menschen, Healthy Planet, Healthy People. But the panel will be introduced after Maria Flaxbart has said why she is such an important key person to promote One Health, and it's a pity that you will not be part of the next coalition. It's not a pity for everyone, but for you, it is indeed. Maria Flaxbart, Parliamentary State Secretary to the Federal Minister for Economic Cooperation and Development and the Commissioner for Global Health and One Health. Please.
So thank you very much, Eckhard, for this really nice introduction. For some people, it might be a pity, but in this case, I'm just belonging to the wrong party. I'm a black one, as you see. And on the other hand, I have decided just to finish my parliamentary career. So. One Health, like world peace, you just said, for a couple of years since COVID-19 is around, we do not just talk about One Health, but we try to realize it. One Health is a really very complex approach and a complex task. It parts from the understanding that human health, animal health, and healthy ecosystems, they depend on each other. They are strongly interlinked. So we have to work together in an inter and in a transdisciplinary manner. We have to leave our silos. This is one of the important things of One Health, to equally protect human health, animal health, and a healthy environment. The reality is that our knowledge and implementing approaches in the One Health sector are often fragmented and in working silos. And so this complicates the ability to quickly address new public health challenges. So the holistic One Health approach comes it emphasizes different disciplines have to work together. We in the German Federal Ministry for Economics and Development Cooperation, we are working to anchor this One Health approach more firmly in our development work with the policies of our partner countries. One Health is an essential task of development cooperation because in low and middle income countries, infectious diseases represent more than 60% of the burden of the disease, and about 75% of infectious diseases, they have the origin in animal world. They are so-called zoonotic diseases. There is another point that low and middle income countries, they are at higher risk for emerging diseases because they are particularly affected by climate change, by loss of biodiversity, by industrialized agriculture. So many, many good reasons just to invest in One Health And so I'm very, very happy being a part of this important panel today at the WHS. Thank you.
Herr Flaxbart, you will be part of the German delegation to COP26. What are your expectancies? What are your what is the best outcome that we could have with a health perspective at COP?
I think we have to look very much more than we did it before to the consequences of climate change, to the consequences of nutrition, of having access to clean water, of the question what we are doing with wastewater, of the question of the support of vaccination. All these is a consequence we have to think about, even in the context of climate change.
Yeah, thank you very much for your introductory statement. We want to jump into the practice of One Health with our first little movie. We're moving to Guatemala.
Zoonotic diseases such as brucellosis and leptospirosis place an immense burden on Guatemala and take a severe toll on already impoverished populations. Outbreaks of zoonotic origin may account for up to 60% of morbidity of infectious diseases in urban populations, but little is known of the magnitude in rural areas with poor formal healthcare services. The One Health project on surveillance and response to zoonotic diseases in Maya communities attempts to fill gaps of knowledge about zoonotic diseases affecting rural populations. The project wants to learn how the Maya population perceives the transmission of these diseases from animals to humans and how local healers diagnose and treat them. It aims to develop a validated methodology for community-based syndromic surveillance, which will allow the collection of samples and the identification of health threats in real time. The project is the first in Guatemala to employ a One Health approach. It involves a collaboration between the Ministry of Human Health and the Ministry of Animal Production and Health, where human and animal disease surveillance are conducted simultaneously. Its transdisciplinary processes, joint problem definition, and co-production of new and traditional knowledge show the importance of health interventions adapting to local ways of living and thinking.
Hello, welcome on the stage, Professor Jakob Zinstag. He just said, well, young man, have you read this book? One Health, the theory and practice of integrated health approaches. In fact, Jakob Zinstag is really one of the leading thinkers behind the One Health paradigm. And he is a veterinarian with a PhD in tropical animal health. Since 1998, he heads the research group at the Swiss Tropical and Public Health Institute, where he focuses on the theory and methods of One Health approach. Professor Zinstag, what we just saw, is this your idea put into practice?
I think so, yes. It's just one case example of how we can work better together between doctors and veterinarians. I think good practices need good science, and good science needs a theory. Before we ever can develop methods, we need to know what kind of theory is behind. And doctors and veterinarians can each work in their corners, and they can make humans healthy and animals healthy. But under a One Health paradigm, if they work together, they can make more humans and animals healthy than they could ever do alone. And the whole methodological approach is to prove this incremental benefit of a closer cooperation of human and animal health. We have to start simple. Let us start between doctors and vets, and then we expand. Then we can include all the environmental science, the food science, whatever we want, the humanities, and not the least the practical knowledge, the knowledge of the governments, the knowledge of the communities. We call this the non-academic knowledge. And if we are able to co-produce a new transformational knowledge between the practical knowledge of you, of the people, of the authorities, and the science, then we can find societally acceptable solutions that we could never find if we just come from top down from an academic desk.
You started this very early to think about One Health. What were the main obstacles when you started?
I think I'm very frank and a bit provocative. The problem were really the doctors, I'm sorry to say. I can give you case examples when we collected Brucella strains in Kyrgyzstan from sheep and goat and cattle, and we asked the Public Health Institute to share strains isolated from humans. They refused outright. And when we collected TB strains in Morocco from cattle, we wanted to know if we find bovine TB in humans. The central hospital in Rabat just refused to share strains. I think it's a power game. It's a power game between human health. Human health is sacrosanct, and the veterinarians. You know, a farmer woman in Kenya told it to me once right away. She told me she had 3 cows, and she told me, I can't believe it. If you would have studied 2 more years, you would have become a doctor for humans, and now you're just a doctor for cattle. That's the reality, and that is the biggest obstacle. Doctors don't let themselves say anything. That's the truth.
I agree. And it's a question of gloves, whether they end here or here.
No. Exactly.
How do you want someone to respect you when you have a glove up here?
Yes.
So, no, I'm joking, but I know how many veterinarians are in the room. Okay, how many human doctors? And how many health professionals in general? Okay. I would like to introduce the panelists with the same question. What is the main obstacle to the One Health approach? Because it seems so logical, it seems so urgent, it seems so, naheliegend. Wie sagt man naheliegend auf Deutsch? Weiß ich es, aber auf Englisch gerade? It seems so obvious. But for some reason, it's hard to get there. Dr. John Amoasi lectured at the Kwame Nkrumah University of Science and Technology in Ghana and is the group leader of the Global Health and Infectious Diseases Research Group at the Kumasi Center for Collaborative Research in Tropical Medicine, and he co-chairs the Lancet One Health Commission. We just had the Lancet Climate Countdown report out with lots of policy briefings. What is the Lancet One Health Commission now, and how did you get there?
No, thanks for that question, and thank you for having me this evening. I co-chair the commission with Professor Winkler Andrea, who sits right in front there. I'm excited about what Jakob said, because he's brought it on. And I think the real challenge, and that's what our commission is trying to look at, is we've had a certain grounding in a certain theory around One Health. I need to maybe speak up a little bit. Should be all right. Okay, wonderful. Yeah, certain grounding or theory around One Health in a way which we recognize has not worked very well, and we need to think a little differently. Now, the question is, how can we do things in a way that questions the existing theory, that modifies it as we move along, in order to achieve the ultimate objective of good health for all living things, human beings, animals, and the environment which we share. And so the Lancet One Health Commission, we started before the COVID came about. And the COVID really challenged us to think about things very differently. So what I'll say is that while the traditional thing has been, human doctors, animal doctors working together for good, we as the Lancet One Health Commission, which Jakob is a part of, think differently about it, that it goes far beyond that. And so we're actually questioning the existing theories and saying we need to look at this differently and establish a new baseline to be able to move forward.
Thank you. I would love to introduce now Professor Wanda Marcotta. She's the director of the Center for Viral Zoonosis, Faculty of Health Sciences at the University of Pretoria in the Republic of South Africa. So we're now moving from Ghana to South Africa, and she is the co-chair of the One Health high-level expert panel advising the WHO and many other multilateral institutions. And could you give us your first impression of what is One Health? Because everybody's talking about it and everybody thinks to agree what it is, but when you're trying to get a grip on, everybody's talking about it from a different perspective. What is yours?
So thank you for this invitation. It's great to be here. I'm not a medical doctor. I'm also not a veterinarian. I'm a scientist and a virologist, so I'm in the middle. So from OLAP's perspective, some of you may have attended this morning's session. One of the things we set out to do as a panel advising the 4 international partners was really re-looking at the definition, and some of the previous speakers alluded to that. I think one of our issues are that we're really not understanding what One Health means, and we don't have a common language, and therefore we battle to implement it practically. So I'm just going to, in short, say what my co-chair Thomas said this morning, and the definition of OLAP is now out and endorsed, and we really hope it's going to be used more broadly by stakeholders. But it's really an integrated, unified approach to obtain optimal, sustainable health for animals, humans, and the environment. And who should be involved? It's multi-sectoral, it's multidisciplinary, but it's also involving communities and all levels of society. I think that point comes out throughout the conversations at this World Health Summit, where we really need a top-down approach, but we also need communities to be involved in what we do going forward. And we know the health of humans, animal, and the environment are linked. We're living in a situation where it's very practical. And we really need to go forward where we have to start thinking not just from the human perspective, but really starting to think from the eco and nature-centric perspective also, how we're going to solve these issues. It needs things like equality is important, bringing in everybody into the conversation is important. But I think a step forward from an international advisory panel is really a definition that brings all of this together. And that people can use going forward. And then what's so great about today is practical examples. You cannot explain something to people just by words. You need practical examples on the ground of how to implement it.
Thank you, Professor Marcotta. We'll have another video just around the corner, but Marisa Beere should have a say. She is a senior epidemiologist specialized in evaluation and design of the One Health surveillance and control program. She is the deputy director of a health research unit in the French Agricultural Research Center for International Development. So we were seeing in the video that we started with that surveillance is really key. And what was your perspective on the One Health definition?
So yes, thank you very much. I'm very pleased to be here today. For me, One Health, it's about talking to each other. It's about partnership and collaboration, and that starts with communication and understanding each other's. And the issue, whether you are at the institutional level, between academics, between vets, doctors, or between disciplines, epidemiologists, sociologists, virologists, it's to really understand what we are trying to do. We are using the same words, but often they don't have the same meaning. And that takes time, and that takes this discussion. So One Health is like any partnership. People need to understand their role, their responsibility, and there needs to be a win-win strategy there. And that's really for me One Health. And surveillance is the same. Surveillance, when you want to get information about health situation or any other events in the local communities, it's about sharing information. People talk to each other, and surveillance is a network of people discussing and sharing information from the local level up to the central level. And the other very important thing so the One Health approach and collaboration aims to improve this sharing of information, to be able to detect early emerging events, rare events, but it's facing the same issues as any surveillance system, is that people are not always accounted for in the system. So if we look at the organization of the surveillance systems in most countries, it stopped at the technical level. So the first person that are in the diagram on the flow of information are the vets or the medical doctors. But the people that are actually impacted and that knows what's happening first are the civil society. They are the local communities. They are the people that are facing the risk every day. They are the hunters. They are the community health workers, etc. And often they're not even accounted for as part of the system. They are at most counted as beneficiaries or source of data. And I think, and that's just been mentioned, that there needs to be a shift in paradigm, and the solution needs to be worked together and developed by the people that are facing the risk every day, and then be integrated as a bottom-up approach in the national legislation to be able to be sustainable.
Thank you. As we see, One Health has many definitions, many perspectives, and we're lacking the environment part on the panel, but we are just talking about biodiversity and the hunters, the people at in question. Another aspect of One Health is this link between biodiversity and people. And I would like to show you a second example, a project that deals with human-wildlife conflicts in India. Please.
Implementation of One Health requires close cooperation from at least 3 sectors: public health, forest and wildlife, and animal husbandry and veterinary. In India, traditionally these sectors do not work together. There are not many institutional structures. There are no forums where these sectors can come together.
Growing demand for natural resources has led to degradation and fragmentation of natural habitats in India. As a result, humans and wildlife clash over diminishing resources, leading to risk of zoonotic disease spillovers. Forest officials, as well as people and their livestock who live in or close to forests, are particularly at risk. Following a One Health approach, this project facilitates an overarching national strategy and action plan on human-wildlife conflict mitigation. It facilitated the development of species-specific guidelines. It also supports 27 veterinary rapid response teams for zoonotic disease management and another 70 primary response teams to enhance awareness and protection at community level. By mapping the movements of local wild animals, the number of interactions with humans can be predicted, making it possible to reduce potential pathways of disease transmission. The project developed occupational health and safety guidelines for handling dead and injured animals. In the COVID-19 aftermath, the project seeks to mainstream the One Health approach into existing regulatory strategies and management plans to further expand the capacity of wildlife veterinary experts and field response teams.
if we really want to take care of our own health and well-being, we also need to take care of the health and well-being of the ecosystem, of wildlife, of plants, and in general, the entire natural community.
Good example. Professor Marcotta, I would love to hear your comments on how this kind of project can help to prevent further pandemics and spillovers. What do you think?
So I think if we look at the history, what we've done worldwide and not in all regions is we just looked for pathogens. We would test animals for viruses and we just expand the list. We know the diversity is huge. So do we need to continue doing that? Do we need to really know every single pathogen that's present in wildlife? Is that going to save us? Or is it really about the factors that leads to that interaction? And that's where One Health is really practical. We need, a pathogen is not going to spill over if the interface is not there. And there's several reasons. This is an example of human and animal contact that happens for a specific reason. And we need to start addressing those reasons. In this case, it's the encroachment. There's just not enough space for everybody and not enough resources. And those are the things that we need to start addressing in pandemic prevention, if we really talk about prevention and the future. And this is an excellent example where 3 ministries are getting together to do that already. And it's not on a large scale. I think that's also the message. It can be a small project. It can start small. It's not like everything needs to change tomorrow, but it's a start to really look at the factors that's important in terms of spillover and moving our mindsets away from just knowing every single pathogen to really looking at the health of animals, humans, and the environment. So that it's obvious that that has got so many more advantages than just pandemic prevention. It is really addressing a lot of other issues also. No.
A provocative question, could have been the COVID-19 pandemic being prevented?
I don't think we know. So I think the flags, the red flags were there. We saw SARS coronavirus 10 years before. Animal markets was flagged. So that's something that we should have addressed better, I think. There's also all kinds of other factors. We should have already in the Ebola pandemics or epidemics, sorry, not pandemics, we knew wildlife plays a role. We know there's an issue if there's bushmeat hunting. Are we addressing those issues sufficiently or are we just listing them? We need to really do practical things to prevent it and make it better and really talk to communities on what is going to work. You can't just stop things. That is not going to be the solution. You're going to have to understand what's the reasons why certain practices happen and what's a practical solution going forward. But I think there were red flags that we should have seen.
This is a question I would love to have everyone on the panel to have a say. Yeah, we're talking about red flags that we were missing. I would love to talk about budgets that we are not spending. To put it more bluntly, if we had invested more money in prevention and more money in the One Health approach, we could have saved a lot of damage to on another level. Would you agree?
I fully endorse what Wanda said. In the aftermath of the avian influenza crisis in 2005, I published a paper in Lancet where I said we need to improve the biosecurity at the wildlife, domestic animal, human interface. And that was unheard. And it basically predicted what was now coming. And the World Bank has already in 2012 published a very interesting economic idea showing that the longer you wait from the environment to the wildlife to domestic animals to humans, the higher is the cumulative cost of the outbreak. So it is in everybody's interest to integrate disease surveillance and response systems at the environment, wildlife, domestic animal and human side. But the reality is worldwide, the surveillance systems are still separated and they don't talk to each other. One good example in Europe is West Nile virus surveillance in Emilia-Romagna in Italy. There, mosquitoes, wild birds, horses, and humans are surveyed in the same time. And they can already prove that they save money by cross-informing each other. And we should just multiply these examples. And I count on you, Mrs. Flachsbart, to advocate this in the European space, that we must integrate human and animal disease surveillance as soon as possible.
I can see Dr. John Amuasi agreeing.
Well, yes, I do agree with what has just been said, but I think there's also this, challenge of the prevention paradox, which Jeffrey Rose talked about in 1995, which is that also with these kinds of activities, the more successful you are, the less visible the threat is. And the less visible the threat is, the more difficult the case is made to continue pouring money into it. So it requires a whole different paradigm shift where we don't put the money where it seems to be really dangerous, but maybe continue putting the money when the danger is not there. But this is a different way of thinking. But that being said, it's two different things, looking at the risk of spillovers and then the risk of spreading. These are quite different. We may not be able to catch all the spillovers. And when I say spillovers, we're thinking also of the humans to the animals. More recently, I was sharing an article with my colleague, Andrea, about leprosy in chimps. Really interesting thing. And it's being thought that actually the humans may have taken this to animals. And think about this, if these infectious diseases go to the animals and then come back to humans, even more powerful than they went out before. That could be quite something else. So there's a bunch of layers there. And I think with the funding thing, it's very clear, it works, the integration is necessary, but the way in which we measure how useful it is to continue putting money there must change.
Marisa, how could we learn from the COVID pandemic that there is glory in prevention?
Well, the thing is that you could inject as much money as you want into trying to detect the viruses, trying to do a bank screen of viruses. And there's been a lot of money spent in the past 20 years on looking for viruses in the forest, and there is a lot of viral bank. But as it's been said before, this kind of information will not tell us when and where the viruses might spill over to humans. And the thing is that to be able to detect that and to prevent that, it has to be sustainable. And sustainability might be very costly, but you cannot prevent an emerging risk if surveillance is not performed in time and it's continued. And the issue is that if you want to be able to detect the first spillovers, and every pandemic has been preceded by a series of spillover, we know that. So we need to be much more sensitive. That means we need to be able to detect those rare events, and we have to be sustainable in time. And the only way to do that is to engage with the people that are actually I've said that before, but this is the key element, that are experimenting those spillovers repeatedly, so they can set up the first proof, the first prevention and protective measures on site very quickly, so it doesn't become an epidemic, and then it doesn't become a pandemic. And that can be very cheap to implement. And we've demonstrated that this kind of participatory disease surveillance with rapid measures being implemented in the local community can be very cheap, or at least much cheaper than having to deal with the pandemic as we are experimenting right now.
Maria Flachsbart.
Yeah, but on the political level, you just have to be aware that these are not only a scientific agenda, a plan, a report, something like this. In Germany, we had in I think 2017 or 2016, like that, a report to the German Bundestag in which it was described that a coronavirus might appear and cause huge damage. some people they read it, but they just didn't believe. You know, there was no political action after that, and now after this COVID pandemic, everybody realizes that just a small virus could cause a huge damage to the economy, not only to the health system, but also to the whole economy, to the social cultural system. Nobody would have believed that before. So we are now in a situation where we can get all this system to be more resilient, to be better prepared, to invest in prevention. We can get all this system on a new track, and we have to.
I remember at the first phase of the pandemic, we went together with Minister Gerd Müller to the Berlin Zoo to draw attention to the meat markets and to try to address that prevention is possible.
Yeah. And
necessary and cost effective. So I would love to have some members of the audience. Someone has a mobile phone near the microphone.
It's ausgeschaltet.
Yeah. Flugmodus has to be renamed. It has to be Bahnmodus or something. But put it off. Rainer Sauerbach. Rainer, just wait a second. I think we have a microphone coming. Oh, you have to. The microphone doesn't work.
So, hearing you, one might think that this is all about bugs and worms, pathogens. Is it not also about heat or about chemicals? You are so dominated by pathogens that I wonder, for example, climate change and heat affects humans, plants, and animals. The same is true for nitrogen loading, for pesticides and so forth. So are you really only focused on pathogens?
So from OLAP's perspective, when our terms of reference is currently zoonotic diseases, but this exact issues came up now that we're also advising on the global action plan. And it's certainly on the agenda. I think we're just starting with the zoonotic diseases first, but those are all the things that's actually important in terms of One Health in the long term.
And they're interconnected, as far as I know. The bats that were one source of COVID and coronaviruses moved to a different level in China through higher temperatures. So we have a triple crisis, which doesn't make it easier to solve. Please.
I fully agree with Professor Sauerborn, but I would like to share an example that it is actually relatively easy to show a direct connection between human and animal health, but to show that connection to the environment is statistically much more difficult. We measured vitamin A content in women, in nomadic people in Chad, and we could directly relate it to the milk they were drinking because they don't eat fruit or vegetable. So logically, you would assume that the milk vitamin A content should be dependent on the beta-carotene in the grass the camels and cows are eating. But we couldn't prove it because the statistical variability was way too high. So clearly, we want to include the environmental dimension in One Health, but methodologically, it's not so easy. And I tell all of the people who work on planetary health, linkages between climate change and biodiversity and health are not so easy to prove. And you want to have very, very good methods to do that.
Well, the most obvious example is that every mammal is dead at 42 degrees body temperature.
Okay, but that's self-evident.
We are mammals.
That's self-evident. We don't need an experiment for that.
No, please. No, I want to be in the control group.
Yeah. Just to comment on that, what Professor Sinstag says is quite true, but it's also dependent on how you frame One Health. In fact, in our commission, we're actually framing One Health to include elements of non-communicable diseases as well. Non-communicable diseases not only in humans, but also in animals. Now, once you look at it in this way, you can see more clearly the connection with the environment and therefore climate and the weather. It is very clear that changes in weather and climate have direct impact on disease spread. Clearly, even for the coronaviruses, we know that when it's colder in the winters, and I know in Europe you're bracing for another wave, perhaps from next month onwards, and we see this quite differently in more temperate regions, how the spread of the infection is modulated by temperature. So I think it's actually more obvious than we think that there is definitely a linkage between the two. And even if you extend that to non-communicable diseases, it even becomes more obvious how non-communicable diseases are definitely linked to lifestyle, and lifestyle is impacted directly by changes in climate and other geographical indices.
And when we're coming back to the example Rainer was supporting, that pesticides, for example, can be measured in human beings in the ground, or antimicrobial resistance and stuff. So that's one example of One Health where you can convince people who have never heard of this very easily that it affects them. So one thing that Healthy Planet, Healthy People Foundation is always trying to find examples that are easily understandable and are getting across to a multitude of stakeholders that we're not doing this for humanitarian reason or because we're good people, but we are doing this for ourselves. And I think that the COVID-19 crisis is the best example that we're not safe until everybody is vaccinated. And so I would love to hear from the panel how these issues of injustice and uneven distribution of budgets and possibilities is contributing to the One Health crisis.
Okay.
But you can say first what you wanted to say anyway, Marisa.
This is not, yes, no, I wanted to react to the question, but I think it might be linked to this as well. So as part of the PRESOD initiative, which I am co-coordinating, which is an international initiative to prevent zoonotic emerging risks, there is two changes in paradigm we are promoting, which is prevention and early detection in a bottom-up approach. And when you thinking about prevention of emerging risk, that means we are thinking One Health as socio-ecosystem health, so resilient socio-ecosystem, which means that looking for solutions to reduce the impact of human activities on nature, and that will link to all the element that you've mentioned, which is linked to chemicals, to climate change, to deforestation, to biodiversity preservation and everything. But the entry point, this is true, is zoonotic risk, but at the end, the solutions is about global health and healthy people, healthy environments. It's people and territory. So this is also a health territory approach. Like you want to make sure that the environment that the people live in is healthy, and then that would limit the risk of emerging. To go back to the inequality of resources and funding to be able to do this, I think there is different level and things linked to that. So first, we really want to promote very low cost solution and very practical solution, because that will also ensure that in very low resource environments, they have also the same chances in improving the health of their environment. The other thing is also to have the political engagement, because you've got countries where the people are poor, but the state is rich. And so there is a need for engagement of states and countries in this solution, and in ensuring the sustainability of the solution that will be adapted and implemented at the local level. And I want to take an example at the international level. In 2006, when H5N1 pandemic occurred and spread over the world, the WHO created this open sources viral database. And so all the institutions in countries had to put the viral strains available, the genetic strains available for everybody. Indonesia refused to share their viral strains because they were arguing that when the virus will become a pandemic virus spreading human to humans, they will not get the vaccines first. And the entire international community was very shocked by the reaction of Indonesia. And so they argued that they wanted Boehringer Ingelheim to produce the vaccine on site based on their local strain that they would share, which they actually managed to get. And 10 years later, coronavirus happened, and the vaccine did not reach the south. They went first to the north. So that's just, yes, we really need to be much more aware of that now.
We have a quota for developmental aid, 0.7. We have a quota from the WHO, 0.1% of the gross national product should go into the health systems of the low-income countries. But the question to the panel, do we need a quota for One Health? Should we have in the new coalition statement that we have 1% of the national gross product of each rich country should go to One Health approach?
So I think
you may
one thing,
say I'm a dreamer,
but
I'm not the only one.
Unlimited amount of money, which there isn't. So I think one thing the world needs to decide is, do we want to do things differently going forward? That's the one question that everybody needs to answer, and it has to be a collective decision, because we've seen that the health of everybody is linked. And if we decide to follow something like a One Health approach, it's much broader than just pandemic prevention. Everybody needs to buy into it. And then we need to restructure not just funding, but how we do things, ministries. And this is now dreaming. But I think sometimes we need to dream a bit and make decisions on going forward that will not be easy. And if we do decide that, then we need to work really hard to change the funding and governmental structures to do that. But it first needs to be a decision to decide how we want to go forward. And it's on an individual level, it's on a high level. Everybody needs to make that decision for it to work.
Do we have the right forum to meet for One Health issues? Because we're talking about interdisciplinary approaches, but for example, in the medical education, all these topics are still not integrated, leaving alone the process on the higher levels. Please.
I think we went back to resource economics. All of you know probably the tragedy of the commons. If there is a limited resource, everybody uses as much as he can, and then the resource is gone. And then came Elinor Ostrom. Elinor Ostrom got the Nobel Prize as a first woman economist for showing that small communities can manage their natural resources in a sustainable way. And when I was on sabbatical 2008, I called Elinor Ostrom and asked her, did you ever think that health could be an output of a social ecological system? And she said, I never thought about that. So at the moment, we are developing a game theory of One Health, which shows that if we cooperate, we will have a benefit. And that is foundational for a new governance system where we can show if the ministries share their budgets and work better together, they have more benefits than if they don't work together. And we have empirical examples from our research on rabies, but also on other diseases, on brucellosis, for example, with which we can validate that. And I hope this will lay the foundation for a new concept of governance based on actually the thinking of Elinor Ostrom that health should be declared as a global commons.
Great idea. We have huge range in this discussion, from new theory, from game theory now to the game in East Africa. Lost in translation. Next video, please.
African countries are repeatedly experiencing the devastating impacts of emerging and re-emerging infectious disease epidemics. These outbreaks have not only exposed the vulnerability of health systems in Africa, but also highlighted the threat to the economic security of the continent.
It affects not just the livelihoods within the household level, but also the national economy in terms of shutting down livestock sales and production. For example, Rift Valley fever occurs every 2 to 5 years in this region, and whenever it occurs, it really causes lots of losses, including human deaths, because it's a zoonotic disease. And then the government has to shut down markets, which prevent people from getting food and nutrition and also selling their animals for income.
Integrated within the wider regional program of the One Health Research, Education and Outreach Centre in Africa and implemented by the International Livestock Research Institute, the project on zoonotic disease surveillance focuses on One Health surveillance by refining and developing risk maps of 3 infectious diseases in Kenya: Rift Valley fever, brucellosis and Q fever. It analyses blood samples and conducts active surveillance for human, livestock and wildlife syndromes associated with these diseases. The project works in remote pastoral areas where veterinary, public health and environment services have not yet been effectively implemented. The risk maps generated will help to detect ecological niches and transmission patterns of the pathogens between humans, livestock and wildlife.
With the new knowledge that we generate, the frontline government staff will be able to act on time, but also act in collaboration with other sectors which are required to control that disease.
Marisa, I've seen you taking notes. It's time for you to comment on this.
This program really emphasized the importance of taking into consideration the social and economics issues that are linked to disease impact, but also how social economics and politics affect the implementation of prevention strategies. So I just want to emphasize what Bernard had said in the video. In the early 2000s, there was an epidemic of Rift Valley fever in the Horn of Africa that has resulted in the collapse of the Somalia economy. A country collapsed, the economy of a country collapsed because of a zoonotic vector-borne disease. And I think it's very important to take this into consideration. So it's not only about health, but it's also about livelihoods and livelihoods of the poorest communities. So this kind of programs taking into consideration livestock as how they can ensure food security and livelihood of the communities are really important, not only at the individual level, but also at the state level. And I just want to make a last comment, which is linking back to the discussion before, that so this year we've been doing a co-design workshop in 11 regions in the world for the PRESERVE initiative, with the aim to really build up the initiative altogether and trying to understand what are the main obstacles to the prevention of the emerging zoonotic risk. And most obstacles that came up were about economics and political issues in many countries. And so this is very important to take this into consideration. And so One Health is about bringing in also the relevant disciplines, so the social scientists, the economics, within the discussion and the picture to make sure that we also address this issue. So as I am an immunologist, a scientist, I cannot deal with political issues, but there is experts in this field that can help to try to understand how we could loop around, or we could make sure that the political question issues are not an obstacle to prevention of emerging risks. Thank you.
John, how important are psychological aspects and social aspects in the work of the One Health Lancet Commission?
Well, in our work, we find it to be very critical. In fact, we've designed what we call a One Health wheel, and we talk about avenues through which we need to follow and also measure possibly how well we're embarking on a One Health approach. Among these is gender-based issues, issues related to community participation, and so on, issues to do with equity and equality, and so on. But something that you touched on, which resonates with what we're doing in the Lancet Commission, was the participatory surveillance. It's something I think is missing.
Say again?
Participatory disease surveillance. Participatory. What this means is you move beyond your doctors and your vets as being your eyes on the ground and recognize that there's a lot more to it. The surveillance system we have currently focuses on the exit points, which is the health facilities and so on. And these health facilities do not operate using a vital registration system, so they are not robust in their own selves. And we've seen this clearly in measuring the impact of COVID in Africa. We can't even measure it because where we plug into itself is not exhaustive enough. So we get an output which is not reliable. It's got to be at the community level. You look at the difference in positivity rates and seroprevalence estimates when you go to a community, it's huge. So think about this. If we need to have this kind of surveillance at the community level, how will the community respond? What will it mean to go to people's homes and ask for biological samples as part of an extensive routine surveillance? Do we understand how people will react? Do we understand if they will understand that this is part of protecting the entire nation, the entire community? It's much more complicated than just about having doctors and vets, at the key places to pick up the signals. It's really on the ground with the people.
Maria, I see you nodding.
Yeah. This was already just said, is one of the critically important questions of the success of this WHO hub for pandemic and epidemic intelligence, because the question of the quality and the quantity of data is critical. They can do what they want. If they don't get data from a good quality and quantity from the countries of the global south, there will not be any success. So what we think is necessary is just to support these countries of the global south, just to get all this data. And so you just asked about a quota for One Health. I would be very, very glad if we reach next year as well the quota of the ODA, this 0.7. And then we'll see. Gerd Müller just mentioned that it would be very, very good aim to reach 1.0. This is a question. Another very important question is not only to leave our silos in science, but to work internationally. The question of multilateralism is so critically important, because what we have seen at the beginning of the pandemic were national egoisms. And this is a real danger. And if we would like to overcome this gap of equality, then we have to work together on an international level. So this is my feeling now, going to a new government in Germany.
Yeah, maybe you change the party.
No, I do not know. I do not have to, not at all.
I would love to hear more voices from the audience. Please. There are two microphones now, so you can move up to the other stand.
Hi, I'm Hira. I'm from the International Pharmaceuticals Students Federation, and also work as a pharmacist in England. So speaking of One Health, and I know we started off the session talking about the definition of One Health and how that is a lot more clearer now. The International Pharmaceutical Student Federation has worked with the medical students, the dentistry students, the veterinary students, and the agricultural students last year to have the very first AMR Youth Summit, because as we mentioned, AMR is one of the kind of overarching topics that involves all sectors. And someone also mentioned medical education before as well. So I want to know if there is any plans, what is happening in regards to implementing One Health in the curriculum of health students, because that's kind of where it all starts. And because it's not something that we're taught about, we figured that we needed to take action, and that's where the Youth Summit came from. We're doing it again this year as well, but having all these organizations from the different sectors has been really beneficial, not only just for us as students that were organizing it, but also participants that joined, because it was open to all people, whether that was microbiology students, everyone. So, and I think that climate health was also mentioned earlier as well, and that's also something that is kind of overarching. So yeah, in terms of like education and curriculum, what's being done, what are the plans, and yeah, because that's where it all starts, is that education of young healthcare professionals.
Yeah, great question. Thank you very much for your initiative, bringing all the students together while they're still at eye level. I would love to collect several questions and then ask the panelists, please.
Yeah, hi, Chris Walter from the Wildlife Conservation Society. Good to see you. Good to see you in real and not only on the screen. So I'd like to be a bit provocative, take 3 steps back and say, we talk about economies and you talk about how many percent ODA you're going to, or how many parts of a percent you want to increase. But what about looking at it from a different way? That we agree that the global crises of climate change, biodiversity loss, global inequities, and public health are all tightly interlinked and driven by the same drivers, right? And they all have co-benefits. If I address one, then I'll get co-benefits in the other one. Stop deforestation, limit spillover, and also nature-based solution. So what kind of an economic model or approach can you imagine? Who's going to pay for this, or how are we going to make people pay for it? Because it's not like we're all responsible. Some of us might be, but most of us have a very low responsibility. But there are obviously 150 corporations in the world who have a huge responsibility. Who's going to pay for these trade externalities moving forward? I'd really like to hear some ideas on that. Thank you.
And a third question.
Yes, hi, Derek Selly from the Graduate Institute of Geneva and the Lansdowne Financial Times Commission on Governing Health Futures 2030. I wanted to build upon maybe this last point and also the very first question that we had, recognizing that the shared environment dimension of One Health is not just about species and sort of, interactions between wildlife and humans, but it's also ecosystem integrity and trends in ecosystem condition, trends in ecosystem extent. And I'm kind of curious from a methodological perspective, if there's, and beyond sort of the One Health Commission, if, to what extent insights coming from ecosystem ecology can inform work on One Health, if there are best practices of ecosystem ecology and sort of mapping of ecosystem condition and extent being fed into One Health approaches.
Okay, so we have 3 big questions: education, the next generation, finance. How can we make people responsible who are taking advantage of the externalization of costs, and also the biodiversity aspect. So we just start with John and with you.
Right. No, thanks for those great questions. I'll touch on 2 of them, the economics one and the ecosystem one. I'll leave the education one for you. Right. So with the economic models, and I'm sure Jakob would have a lot to say about that as well, since it's his expertise. The Lancet One Health Commission, we've looked at this quite a bit, and we've come to the conclusion that the current global economic system does not intrinsically support a One Health approach as we would have it. many people have put forward alternative models. You have the circular health, you have the donut economy by Kate Rayworth, you have the, if you read the Dasgupta report, it also tells you how the current global economic system just will not work. So what we are putting forward, and
what's the name of the report?
The Dasgupta report.
Okay.
It was published in the UK a couple of months ago. All these show clearly that the current system does not work and will not work moving forward. It's going to take quite some time and will be very painful to change this. So what we've got to do is to harness what we have currently, like what you're saying, try to get to this 0.7% of GDP spent on One Health or whatever you want to call it. But at the same time, recognize that we need a fundamental change in the global economic system. For example, trees standing in the forest with their roots in the ground are worth less than trees that are cut down and logs in a container. I mean, that's just wrong. This kind of thing needs to change. And so that's the economic side. And then on the ecosystem side, in our report, we're really going deep into this to the best that we can within the space we have. And we speak to ecosystem cascades, where you show how changes in an ecosystem ultimately impact on animal and human health dramatically. And so I'm sure when this report comes out, hopefully you will be excited to read more about this ecosystem cascades and how we link them to human animal health and ultimately to economies. But it's quite a well-researched area, maybe not got as much attention as it should, but it's been well demonstrated and very convincing evidence. I'll stop here.
I'm very glad I don't have to answer about the economic questions. Thank you. So now the education, it's the key. And I think education is the key to address the issue that Jacob started with about the issue with the doctors, the medical doctors. Because when you train people together, so they learn the concept together, then they understand what it means and how they see it in their different sectors and fields, and they understand each other. So we've been working, there's been a lot of work done on trying to build up curricula on One Health education in Southeast Asia, in Africa, and in Europe, but more recently, actually, in Europe. And the idea is really to train young medical students, veterinarians, agricultural students, environmental, ecological, and we need to bring in sociologists, economists as well to be trained all together within a One Health approach, so they can really exchange, work together, collaborate, and that is a real key. There is one issue with education that is very important also to address, and that has not been addressed yet, and it has to be considered very, very importantly, is that when you train as a scientist, you do a PhD in a specific field, you become an expert in a field. In the past 10 years, we've been training students that have become experts at the interface. And there is no discipline called such as interface science. So they had to register to epidemiology, they had to register to social sciences. So they're kind of tagged into a specific field, but they are not, they are experts in many different disciplines, socioeconomics, epidemiology, and ecology, for example, depending on the topics. So they're not as a strong expert in one specific field, but they can really work with all the different disciplines, and they can do this work at the interface. And that doesn't mean that we need to get rid of all the specific experts, because you also need to have people that are very, very trained and very specific in their topics, that they can really dig the ground, do fundamental science that can feed those interface experts to be able to address these complex issues that is socio-ecosystem health and health of living and planetary health as a whole. So.
Thank you very much. I'm not an expert in education things, but I can fully agree to that what Marisa just has said. Perhaps politicians are something like an interface expert, because we have to deal with all these information of the different experts of the different scientific fields of our population, of our constituencies, who want us to do something in the one direction and sometimes in the other direction. And so perhaps we could be something like this. But the question is, who will pay for all of this? In the old world, as it is going on in the moment, we took over a responsibility, and our budget in our ministry, it arises in the last two periods from 6.4 billion euros to 12.6 billion euros. We invested much money to ACT-A, for example, 2.2 billion. We invested into new One Health project, 150 million in last year, and hopefully 15 million this year as well. So I think we have to live as politicians in reality, and I really appreciate ideas how we could overcome this inequality. But we have to live in this world, and so I would say just those who live in wealthy circumstances, they have to take the responsibility to help, to support those who have to struggle most with climate change, with the pandemic, and with other challenges. So this is my point of view. Thank you.
Thank you. We have these two statements, and then we have another movie. So if you have really urgent questions, be aware that we're running out of time. So who wants to say something? You two are the last. So go to the microphones already now, please.
So OLAP, on the education question, it is actually something that OLAP's also looking at as part of the bigger picture. And I think the WHO also mentioned this morning how important it is to start training the youth differently, because they're the generation that's actually going to have to save us from the next pandemic. And so education is very important. I want to get to the question on ecosystems. So one of the things that the panel is currently doing is designing, or we want to put out how One Health surveillance should look like. So this is not just bringing human testing and animal testing together. It's really also looking at information about ecosystem changes and how we can share that. The reality is, I mean, I'm from Africa. I know in the countries that I work in Africa, it's not so easy to get that information. It may be on a researcher's desk or in some NGO or somewhere on a computer. It's not shared widely, and we really need that information together with the pathogen information to make informed decisions. So thinking about intelligence hubs and things like that, if we really talk about One Health surveillance and data reporting, it needs to be more than just pathogen detection. So from our perspective, from the panel, this is where we would ideally want to go in the future.
Just two brief comments on education and economics. The first is, in my class, I teach every year maybe 20 to 30 students. But now we have developed a massive open access online course on a British platform, actually, FutureLearn. And now I have every year 1,000 students following our course. So I think we should make full use of the digitalization to reach out to a much broader community of learners. The second point is this free of charge? It's free. It's open access.
Great.
Hit on One Health FutureLearn and you're on it for free.
One Health FutureLearn.
FutureLearn.
I can really recommend the course.
Now,
you have one of the 1,000 disciples here, and I can highly recommend the Planetary Health Academy, which is also a free online course.
Now, sorry for public relations. Now, I am provocative and I argue that One Health, we don't need to pay for One Health. One Health pays off, and we have evidence that One Health pays off. If you invest in the right place, you can save so much money that it becomes beneficial. In Mongolia, we could show that mass vaccination of cattle and sheep and goat was not beneficial for public health alone. The savings was less than half of the investment. But if we add the savings from the private patients, the income loss of the private patients, and if we add on top of that the gains from increased livestock production from the investment, there is a benefit cost ratio of 3:1 for investment in brucellosis mass vaccination. Same story for rabies. You can keep treating humans with post-exposure prophylaxis for dozens of years. You will never eliminate rabies. But if you invest in dog mass vaccination, it pays off after 10 years. It is less costly than human post-exposure prophylaxis. When I told this to Gavi, Gavi said, this is not in our strategy.
Yeah.
Just to give you another example where the barriers are.
The doctors. I heard you, Jakob. But I also hear and we've all seen his Swiss eyes glowing. 3:1. It pays off.
Pays off. It
Yes.
pays off.
Yes. Sicher. Please, your question.
Dr. Jean-Paul, Malteser International. I come from Congo. I want just to add something because I appreciate when Marisa speak about community surveillance and Maria say about the local data. But I want to share some challenge we get in DRC for response, Ebola response. My English in few, I won't speak in French. My colleague can translate.
Okay.
Ok. Alors, je voulais partager juste la surveillance à base communautaire. Si cela est utilisé seulement pour relever les données par la communauté, cela ne suffit pas, ça ne permet pas à la communauté d'adopter les comportements et finalement, ça crée la méfiance avec les experts de la santé. Par contre, si on intègre la communauté bien dès le départ dans l'analyse de tous ces risques, ça permet à la communauté, ça permet aux experts de comprendre le contexte dans lequel la communauté se retrouve, leur perception. Et là, alors, la communauté va collecter les données pour riposter à l'épidémie. Et pas seulement collecter les données et envoyer à la hiérarchie. C'est ça ce qui crée la méfiance et ce qui a fait que la communauté avait réagi contre les experts et les a tués aussi. Il y a eu des morts d'hommes.
Give her a chance to translate.
It will be very hard. I try. So from our experience, we learned that it is not enough to just work with the community for the community surveillance part to give us the data we need, but we have to include them from the very beginning, from the risk analysis to detect the risk in the community to really understand what they're going through. And this would also reduce their hesitance to work together with us. And really, yeah, so we saw that sometimes it's not working very well. Like, for example, in the Ebola epidemic, there were resistance from the community, which resulted even in deaths of health personnel that was attacked.
Okay, thank you. And your question, who are you?
So I'm Olga Rostkowska from MedTubeNet. It's a educational platform for doctors and healthcare professionals. And I just want to give a brief note on medical education, like what we do at the Medical University of Warsaw. We coordinate some case-based learning projects where we gather medical students, pharmacy students, also veterinary students, and some other like healthcare professional juniors, and we solve problems together. They are given scenarios they have to work on. Let's say an outbreak of a zoonosis in a rural area in Poland. Okay, what can we do from the side of the vets, of the doctors, pharmacy students, and so on? And they already learn how to collaborate. As we all know, it's very difficult to change curricula anywhere, But these projects are being run by the European Medical Students Association. So it's a local organization of students. So it's a very, very bottom-up approach where students, there's something for students because students already see the need. We have to learn how to collaborate. And then later on, when those students graduate, they already know that it's so much important, it's so much fun often to cooperate and to learn from each other. So it's a very practical example of how we can do this from tomorrow on.
So say the name of the platform again?
It's not a platform, it's just a project run by the EMSA, European Medical Students Association in Warsaw.
Okay, thank you very much.
Thank you.
We have one more example from the videos, and then we have a closing round, but we are doing the wrap up. Please.
For me, One Health is all about being properly prepared, and the ultimate goal for me is that we move some of our preparedness activities more downstream. If we only respond to an outbreak when the virus has transferred from the animal to the human and there's widespread human-to-human transmission, then it's too late.
In the past, the health systems in the Economic Community of West African States, ECOWAS, have been hit hard by outbreaks of Ebola and more recently, for example, dengue, monkeypox, cholera, and now COVID-19. These outbreaks have shown that the levels of emergency preparedness and hazard prevention are low. Insufficient communication of health risks and challenges in the coordination of stakeholders within ECOWAS have hindered an effective cross-border response to disease outbreaks. The One Health project on pandemic prevention in the ECOWAS region supports the establishment of disease control mechanisms that will enable more comprehensive, timely and effective control of outbreaks and epidemics. It has helped to develop a strategy and standard operating procedures for interinstitutional communication and coordination in disease control, and supported the development of a procedure manual for the ECOWAS Regional Rapid Response Team. The project enabled the training of disease control staff and the introduction of SORMAS, the Disease Surveillance and Outbreak Management System, which is now being used nationwide in Nigeria and Ghana for the control of COVID and other highly infectious diseases.
If we could change some of our processes and procedures so that the detection point was earlier on in that life cycle approach, then I think that we could save ourselves a lot of time and money and human lives and animal lives and economic disruption.
Another good example. And obviously it's easier to implement SORMAS in the whole of Africa than in one Bundesland. Yeah. Maria.
You are completely true. I thought I should do the summary. They are not allowed just to bring themselves in, the other panelists.
Yes. We're talking a lot of collaboration and shared views. And I have to keep the time, but if each one of the panelists has one thought on the questions that we had regarding Ebola and how to build trust in the community, that was vital. And maybe say something that you wanted to say all the time and didn't get the right question. So I would have one last row of no question. Microphone over to you, and then
great.
You wrap it up. We start with Jakob.
Yeah, thank you. And in response to our colleague from Congo, je vous répondrai en français après. Oh. I say it in English now. You're absolutely right. I mean, and this is also how we do our One Health research. When we go somewhere, first of all, we establish research partnership with partner universities or research institutions at eye site. We decolonize the research. We work really at eye level, number one. Number two, we immediately engage with communities and authorities. we listen to them first before we come with solutions. We listen and ask, what are your problems? How can we solve them? And in this way, we engage in this participatory transdisciplinary process where communities and authorities most of the time come up with much better solutions than we academics could come up with from our academic desks. So I would really like to emphasize that One Health is profoundly transdisciplinary, which means we co-produce academic and practical knowledge to a transformational knowledge for the societal problem solving. I was a member of the OECD working group on transdisciplinarity. There is now a policy paper out by OECD that promotes these transdisciplinary approaches for all issues of societal problem solving. So that is for us a center of the One Health approach. Thank you very much. And thank you also for inviting me.
Sure.
Thank you. I just want to echo that. And I, from my side, how can we do this practically? Because we talk about barriers and all kinds of funding that needs to change. Do we really have to wait for that? If we, for instance, get funding just to do human surveillance, nothing prevents us from having everybody around the table in the design of that project, although only a certain part is funded in the end. We need to bring everybody into the conversations from the beginning, including the communities, fund what we can, do a stepwise approach and go forward. And in the end, we will include all the aspects of One Health. But the conversation needs to at least start with everybody around the table, including the chemicals and the pesticides and all the other things that was also mentioned today.
Yes, I think we all agree on this great concept. And as I've said before, One Health is about collaboration between people and people engagement. And we have to stop talking about the local community as data sources, and we have to stop talking about surveillance as data collection process. Surveillance should be the first barrier of action and the first level of action at the local level. So the people need to be independent and understanding their role and responsibilities in being able to detect the event and to be able to react quickly to become this first proof, barrier proof. So I fully agree with our colleague from Congo on that. We have to revise our terminology as well and our positioning. I would like to emphasize the fact that this change in paradigm, really thinking about prevention at the local level by finding solution to reduce human imprint on the environment and to improve early detection and reaction by the local community for the local community within this bottom-up approach is at the heart of the PRESOD initiative that we are trying to promote, and we hope that this initiative would become much more endorsed by a number of states and international organizations that can join in, so we can all collaborate together. Collaboration is the key at all levels, local, regional, and international level. Thank you very much.
Well, thank you very much. And I think that the theme coming out of this is pretty clear, the need for the community to be at the heart of it all. Based on this, I really want to call for a whole look at the concept of health systems and really speak to thinking about the concept of One Health systems strengthening. And I put this forward at a meeting, a small meeting where Dr. Sumia Swaminathan was present, and she seemed to like the idea. And I hope that the WHO will listen to this as well. And thinking about One Health system strengthening, to recognize that perhaps one of the building blocks which may be missing is the research and surveillance. And this research and surveillance must adopt what I'll call a community-based participatory surveillance approach. I think I'll stop there because of time.
So I would like just to give a short summary. As far as I have understood, three things are of crucial importance. The first is about knowledge and scientific cooperation, is about leaving the silos. It is about to improve communication and collaboration at all levels, not only at the scientific level, but also at the politician level, but also of collaboration and education from schools, children to NGOs, from academia to policymakers, and to involve the private sector as well. Second is about social skills and social communication. Efficient projects have to be in a mindful, culturally and gender sensitive approach. This is elementary in any One Health project. And the third thing is about coordination. We have seen so much new projects. 4 of them were presented here this afternoon. So we have to coordinate all these initiatives. One of the right steps in the right direction is OLEP, the One Health high-level expert panel. And I really wish that the results you are working on are heard then in the political and in the scientific context. So One Health challenges are an international approach, partner countries of the Global South. And this is a very, very important thing for me. They must be supported where necessary. But on the other hand, we have to show where we can learn from them. Very important is an early involvement with partners at eye level. So the COVID-19 pandemic has opened a window of opportunity, for One Health, for a holistic view of health and development, for the importance of being prepared and prevent. And last but not least, thank you very much to the World Health Summit for the opportunity, giving us a wonderful platform for discussing this very, very important question. Thank you.
Thank you to the great panel. Thank you, Maria Flaxbart. Thank you for a wonderful discussion and an audience. We need more interface science, and we need a different way of economic growth, where a tree with roots is worth more than in the form of a IKEA cupboard. That's what I learned from the panel. Thank you very much. Have a great World Health Summit evening, and see you on Tuesday with Healthy Planet, Healthy People. Bye.